So we're going to talk about heart failure because all of those congenital cardiac defects that we talked about can lead to heart failure. I'm not going to spend a lot of time on heart failure because you already did that in level 2. So this should be all review. So I'm going to skip right to the end. All right. But basically, if you have left-sided heart failure, it is an inability to pump blood to the body, right? The left side of the heart, the left ventricle pumps blood out to the body. Where does it get blood from? The lungs. Like, you guys should be able to just say that. I don't know if you're just not awake yet or if you're confused about that, please see me after class. But it gets the blood from the lungs. So if it is failing and it can't pump it out to the body, it's backing up into the lungs, which is why you get all the lung symptoms, the congestion, the dyspnea, the cough, all right? With right-sided failure, it can't pump blood to the lungs. So where does the blood come from? The body. So if it's backing up to the body, that's why you get the symptoms of JVD and ascites and edema, all right? For the most part, you have left-sided failure. And then because of the left-sided failure, because the left side fails and it pushes blood into the lungs, that right side has to work really hard now because of that extra in the lungs. Then the right side fails. You very rarely have just right-sided heart failure. There is a condition called cor pulmonale. You will learn about it in level 4. You don't have to worry about it right now. All right? But most of the time you have left-sided failure and then the right side fails because it's working against the lungs because the left side is failing. All right? And again, we keep talking about it. It's all about supply and demand. Basically, they have this much supply and we need to limit demands. Because if this is normal and now their supply is this, they can't take those extra demands. So we have to keep demands at a minimum. So we want to increase tissue oxygenation and decrease oxygen consumption. We decrease oxygen consumption by decreasing demands. That includes removing any excess fluid or sodium, because the more volume that the heart has to pump out, the harder it has to work. And again, we're trying to decrease the demand of the heart. That might mean limiting activity. It might be positioning them. It might be some supplemental oxygen. But it's all about supply and demand. Now, is a test question going to say we need to decrease demand and increase supply? No, it's going to give you examples of that, like limit activity, taking the fluid off, decreasing sodium. So you've got to understand the concept and then understand what things contribute to that concept. And kids in general are going to have the same symptoms. We've already talked about it. They tire when they feed. That's a demand on them. They get irritable because their brain is not getting enough oxygen. They have cool extremities. They get diaphoretic. They club. All the symptoms that we've already talked about. All right. The big thing for kids is that, again, who is taking care of these chronic cardiac kids the majority of the time? The parents, the family, right? So education is going to be extremely important because at the end of the day, they are still kids and they still have developmental needs, like the need to play and the need to be disciplined and the need to have limits and the need to interact with others even when others are sick and, put them at risk. And we need to oftentimes have feeding alterations for them because we don't want the demand of feeding to be so great. So higher calorie formulas, doing things just like we talked about COPD. We wouldn't give them a bath and do all their vitals and give them all their meds and then say, okay, now sit down and eat. They're exhausted from all of that. So just a kid with a cardiac issue, it's the same thing. We're going to make sure that they're like totally prepped and ready to go for a feeding, that they are nice and rested prior to feeding. And then medications. we really need to educate the family about the medications and what side effects. Because oftentimes these cardiac kids get sent home and they're told, follow up with your cardiologist in 2 months, okay? But if they start developing toxicity, are we going to wait 2 months to see that doctor? Or do we want them to get to the point where now they're in the ER with a complication? No, so we're going to tell the parents to look out for what things? Shoot, I got to remember farm. Halos, blurred vision, the nausea, vomiting, the bradycardia. And is a kid going to say, I have nausea and vomiting? No, they're going to say, my tummy hurts, right? They're not going to tell you that I have halos around my eyes. No, they're going to say, I see green spots, okay? So you have to educate the parents on what a kid might say. When you get all technical, it goes right above their head. So it's great that you can sound smart, but you haven't done your job if you haven't educated them correctly. You need to talk to them about, beta blockers, that they have to learn how to take a blood pressure and check a pulse so that they don't bottom out their kid. That may have to be on diuretics so that they can decrease the extra fluid and decrease the workload of the heart. But that might mean that your kid pees out all their potassium, which then could affect the electricity of their heart. So we have to make sure they're on a potassium supplement. So and that these could all interact with each other, because what supplement interacts with digoxin? Oh, potassium. So all of these things that they're on can interact with each other, have side effects, and we need to make sure that we're educating the families, because we don't want to wait 2 months. If a kid starts having effects 2 weeks later, we want the parents to right away say, hey, the kid's complaining of seeing spots in their eyes. Can we get in to see that cardiologist sooner and adjust their medications? Because we don't want them to end up in the ER really sick. All right. So that was all the congenital heart stuff. And heart failure is often a result of their congenital heart defect. But we are going to talk about a few acquired heart diseases. So rheumatic fever, it is a self-limiting disease. And the reason we talk about it is because it causes cardiac valve damage. Okay? It typically happens 2 to 6 weeks after a group A beta hemolytic strep infection. So strep throat. The kid gets strep throat, it goes untreated. Because if they're a mom like me, the kid says, I have a sore throat, and I'm like, suck it up. And then, 3 weeks later, they've developed this, right? So, lots of times we kind of poo-poo sore throats, okay? So, the kid has a sore throat. It's not maybe a bad strep. We don't get treated. 2 to 6 weeks after the infection, they have this inflammatory disease. Rheumatic fever is the inflammatory disease to strep throat. The peak incidence is about 5 to 15 years of age. And again, these are all symptoms or a reaction to. So the body will have this inflammatory response. They'll have the symptoms, and the symptoms will eventually go away on their own. We can't treat rheumatic fever. We can just treat the symptoms symptomatically, all right? Just make them feel comfortable. Once they've developed it, they've already developed it. We're just going to make it comfortable while they ride it out. It's like having a cold. I can't treat a cold. I can't make it better, but I can make the fever go down. I can do a decongestion to make me, not so snotty. So we diagnose it by the Jones criteria. This is the major criteria. It's joints. Joints is the J. And basically they get really painful, tender joints. And they have polyarthritis, meaning that it is in multiple joints, okay? Oftentimes it's the ankles, the knees, the elbows, the wrist. And again, this is an inflammatory process, so it's going to be warm and hot, and they can migrate. So the kid could complain of wrist pain and have red, swollen wrist, and then the wrist gets better, but the elbow hurts, okay? So, and it does not have to be symmetrical. It can be, but they just have multiple joints that are red, swollen, hot, painful, and very tender to touch. Again, the heart, we can cause heart valve damage because of the inflammatory response. So they develop an endocarditis. And this could possibly cause permanent heart damage, which can cause EKG changes. They can get chest pain, heart murmurs because of it. So just like when we talked about those congenital heart defects, we want to decrease the demand on the heart. Are we seeing a theme here? I think I've said that like 700 times. Okay. So when we talk about Jones, the J is joints, the O is really a heart. Isn't that cute? No? Okay. The N is the nodules. So they get these small, painless nodules on bony areas. So kind of on the elbow, on the knuckles. They'll feel like these little, you know, a nodule underneath the skin. Sub-Q. The nodules themselves aren't painful. The joints are painful, but the nodules themselves are not. The E is the erythema marginatum, which is the rash that they get. It can be flat or just slightly raised, and it's very diffuse, ragged. It doesn't bother them either. It's painless. And the S is the syndrome chorea. And this is where they have jerky, involuntary movements of their body. And it's often their hands or their feet or their face. So they'll just sit here and like, but that's an awesome picture that you guys are watching right now. Those who are paying attention are enjoying it. So that's the Jones. So joints, heart, nodules, erythema, syndrome chorea. Okay. Again, all we can do is keep them comfortable during this. Minor criteria include fever and fatigue, but again, those are super non-specific and don't really diagnose rheumatic fever. You have to have the 5 major criteria. Diagnostics aid in the fact that, like when we get an ESR or CRP, just like mobility, they're not specific for rheumatic fever. A high SED rate, which is ESR, or high CRP, C-reactive protein, they're just inflammatory markers. They get elevated anytime you have any kind of inflammation or infection in the body. So if you have like an appendicitis, your CRP is going to be high. So they'll be high, and they will help diagnose that you have some kind of inflammatory process. It doesn't tell you specifically have rheumatic fever. But they get them to also help monitor to the disease. They help monitor them as much as they help diagnose. So they'll come in and they might have a CRP of 20 because of this inflammatory process. And then it will go down to an 18, and then a 13, and then a 10, right? So what we want to see is them trending down. That's why, like on your care plans, you don't want to just give me one CRP, because if you tell me the CRP is 10, I'm going to be like, oh, it's elevated. But I don't know if that was less or more than the day before. So with those, we really are monitoring the trend of the inflammatory process, not really helping truly diagnose it. We will swab them for strep. Even though the disease might have happened 2 weeks ago, 6 weeks ago, the organism can still be living. Even though like maybe the sore throat went away, they could still technically have the disease. And if they do, we want to treat it. Because as long as they continue to have strep throat, they will continue to have this inflammatory process. So, but we use penicillin to treat. We're not treating rheumatic fever, we're treating strep throat. And again, this is where they might trick you up. They might say, you know, they're not going to say maybe rheumatic fever, but they'll give you, a kid comes in with painful tender joints, you know, jerky movements of the hand, a rash, you know, strep throat is negative, or, you know, something about the strep throat, but basically that you don't need to treat, like how is treatment going to go? It's not going to be penicillin unless you have a positive strep throat, okay? We're also going to use aspirin or naproxen. And again, I know that normally, like you guys are like, oh my God, I learned never to give aspirin to a kid under 18. This, and you're like, that's what they told me in farm. This and the next disease process we're going to talk about are your exceptions to the rule. We use aspirin because of its antiplatelet effects and because what is the biggest risk they're at? Risk for that carditis, right? So this is going to decrease the workload of the heart by not allowing any clots or any issues. And again, we really worry about like Rye syndrome with younger kids, okay? Like less than 2. And what does this affect most of the time? 5 to 15-year-olds. But even in the next one, it's younger kids, but it's okay. I promise. For this disease, aspirin would be a right answer. I always have one student who like refuses to want to give it. They're like, no. Again, we want to decrease the workload of the heart. So bed rest, focus on nutrition, and just emotional support. We can't treat rheumatic fever. We can only treat them symptomatically. And we prevent it by treating strep infections. This is why we swab everybody under the sun. I mean, you come in and you're like, I have a tickle in my throat, you get swabbed, right? Everybody gets swabbed because it's called a POC, a point of care test. It is really quick. You often will swab them with 2 swabs together. You swab them, you use one for point of care. You basically use the little strip, you put the liquid on it, I don't know what it's called right now, the reagent on it, and you can see if it comes back positive or negative. If it comes back negative, you take that second swab that you use and you send it off for culture, and then you treat if it comes back positive. So a lot of times the point of care will be negative, but the culture will be positive. So we go ahead and swab everybody.
What's the second one, treatment?
Treat strep throats if a sore throat swab. Salicylates. So aspirin, naproxen. Oh, everybody good? This is what I've been kind of, I don't want to say hinting at, but talking about. This is the bacterial endocarditis. So basically, an organism enters the bloodstream from some kind of localized infection or treatment. So they have dental work and bacteria enter, or they have surgery and bacteria enter, or they happen to have like a deep enough cut and bacteria enter the bloodstream. And when bacteria enter the bloodstream, they lodge on that abnormal or damaged heart tissue. Oftentimes the valves or their inner lining of the heart. We talk about it here a lot because of the prophylactic antibiotics that we need if a child has ever had heart surgery. So we do talk about it, but we really see it mostly in older adults and IV drug users. So men get it more than women. They have really good prognosis. And if you suspect it, I'm going to put everything up here, sorry. If you suspect it because of the clinical manifestations are really vague. They feel it's flu-like, right? And it's systemic because it's a blood infection. So they feel kind of like they've been hit by a train. They've got fevers, they're fatigued, they have achy, muscles and joints. They may not, eat as much. They have some weight loss. The thing that differs from it is that they will have some chest pain or dysrhythmias, and their history will confirm it. You'd be surprised how many people come in and they're like, yep, I'm an IV drug user. Because they're just very honest in the ER. They like to overshare. So if we suspect it, then we'll go ahead and get a blood culture. The blood culture you cannot get from an IV. You have to get the blood culture from a peripheral stick. You have to make sure you clean that very well. So you get your peripheral stick, you get that blood culture, you send it off, then you can put the IV in, then you start antibiotic treatment. So just like before, you got to get that culture first. Again, a SED rate, a white blood cell count, they don't help you really. You can't get a white blood cell count and be like, oh, they have bacterial endocarditis. It doesn't diagnose it. But again, we get them because it helps trend their disease process. So if they come in with a white count of 25, and then a week after treatment, there's still a white count of 25, it probably means your treatment didn't work. Now, granted, you're not going to wait a week, but we really use those numbers to guide treatment. And again, that's where NCLEX is going to be looking in your care plans. That's where we want you to see that you're understanding these things, is that if I do an intervention, does my intervention work? And so a lot of these diagnostics that we do help guide our interventions. Because if I came in with this high white count, and I know it's a bacterial endocarditis, and I start antibiotics, and my white count still stays high, it probably means my antibiotics aren't working, right? So that means that I either need to change my antibiotics up or fix something, because something's not right here. All right, it allows us to investigate. We do an EKG, chest x-ray, echo, because there can be damage to the heart, and it can change the function of it. Treatment is basically IV antibiotics. And it is long-term IV antibiotics. So it's 6 weeks. And most of the time, they get a pick placed. And then if it's a kid, they send them home with home health care. And the nurse comes twice a day to give them their dose of antibiotics. With IV drug users, are we going to send them home with a pick? They would super appreciate that, to have that direct access. But it's obviously not how we want to treat them. But they still need to be treated. So these patients end up sitting in your hospitals for weeks on end because they need IV antibiotic therapy the entire time. And they can't be trusted, quite honestly, to go home with direct access. So they tend to be non-compliant. They try to check out AMA with their pick. They have friends sneak in stuff. So it can be a hot mess of a nightmare on the floor when you're treating this. And they are not candidates. Oftentimes, bacterial endocarditis will damage the heart valve to the point that it won't work properly. So they'll start developing some signs and symptoms of heart failure, and they are not candidates for valve replacement until they can prove that they're no longer IV drug users. So they have to be in rehab. They have to test negative for drug tests. I think it's 6 months. It's quite a long time. So we really do need to treat them, because if we don't treat them, they're going to damage the heart more, and they're not candidates to even get repaired. So So kids are way easier when they have bacterial endocarditis, and they recover way easier. All right, that one's pretty easy. And then last but not least is Kawasaki. Isn't that fun to say? Yeah. All right. So Kawasaki disease. It is a mucocutaneous lymph node syndrome. Basically, they have a systemic vasculitis, so it's inflammation of the vascular system. And we don't know why. So the etiology is unknown. We don't know what causes it. But again, it's self-limiting, meaning it's going to run its course. We are just going to treat the symptoms and make sure the kid stays comfortable. And 80% of cases occur in children less than 5 years of age. And it's something to kind of remember, keep in your back pocket. There are lots of disease processes that you guys are learning about, and lots of things. You need to know what stands out with each one. And that's why I tend to group things together, because if they have similar, like, don't sit there memorizing all the similar. Stand out what makes it different, because NCLEX is going to ask you about that. Like, they want, like, 80% of the cases are children less than 5 years old. They're going to give you a Kawasaki kid that's less than 5 years old, because they're looking for horses, not zebras, right? When we look at a horse or a group of horses, we're looking for horses. We're not looking for the random zebra among them. Are there random little zebras every now and then in medicine? 100%. But NCLEX doesn't want you to know all the randoms. They want you to know the generalizations, because they want to make sure that you recognize them so that you can protect your patient. Generalizations of red flags, generalizations of side effects for medications. So always when you're looking at a disease process, think to yourself, what will make me help diagnose this? What sticks out about this disease process that makes me say, oh, I know it's this? So if they're going to describe something to you and they say like a rash, you know, and they describe something and you're like, oh God, I don't remember if it's rheumatic fever or, you know, Kawasaki, something like the age is going to be the thing that sticks out. They're going to say a 4-year-old or an 11-year-old. And you know that Kawasaki isn't common in 11-year-olds. So you've got to use those clues. What makes it stick out to me? How do I know it's this disease? And then what's going to be most important for me to treat this disease? Or what will be the most important thing? And oftentimes, and I know you guys hate this, there are several right answers, and they want the most right answer, and you all want to punch us because you're like, they're all right, okay? I get it. It's frustrating, but you have to think about it is if I could only do one thing, if I walked in this room and did one thing and then had a heart attack, what would benefit my patient the most? I know that'd be a very dramatic day. I mean, imagine your poor coworkers. But, but that's what they want to know, is that if I could only do one thing moving forward, what would I do? All right? I get on my tangent, I'm sorry. All right, good prognosis for Kawasaki. And just like rheumatic fever, where it had specific criteria, Kawasaki has specific criteria. All right. You have to have 5 of the 6 criteria to be diagnosed. One is a fever. And it is a very high fever. It is often the first symptom we see. And this fever is not responsive to medications. So the parent will come in and say, they've had this 104 fever and I've been giving ibuprofen and Tylenol and it's not touching it. They have bilateral injected red eyes. So their eyes are just really red, weepy. Again, remember, it's a vasculitis, okay? It's inflammation of the vascular symptom. So all the blood vessels are kind of on fire. Their tongue gets to be like a strawberry tongue. So again, it's very bright red, and it's pitted like a strawberry. And if you've ever seen someone with Kawasaki disease and they say it looks just like a strawberry because they stick their tongue out and it's like the shape of a strawberry and it's got all the little pits. It looks just like it. Their extremities, basically what happens, their hands and their feet mostly, they'll get edematous and they peel. So they'll have like peely, swollen hands and feet. Oh, I forgot one up there. They also can develop a rash, and then they can get cervical lymphadenopathy. So their cervical lymph nodes get inflamed. And again, they need 5 out of 6 of these to be diagnosed. They can get these other things like diarrhea and sore joints. They can get those as well, but you have to have 5 of the 6 criteria, the main criteria. So we treat it with high doses of IV gamma globulin. Again, remember, we don't really know what causes it, so we can't treat the cause. We're just treating the vasculitis. So we're treating this inflammatory process. And when we give the gamma globulin, it kind of calms everything down. All right? We also can give them aspirin. Yes, you can. It's okay. I promise. For Kawasaki and rheumatic fever. And I want to say your book says it has anti-inflammatory properties. Like your WOM book maybe says that, but... What?
Aspirin is used as an anti-inflammatory dose.
Yeah. Oh. But they do use aspirin for it. And we're going to monitor their cardiac status. Obviously, we talk about Kawasaki here because it affects the heart. Oh, thanks, guys. You guys are waking up. You're almost there. So it probably puts more demand on the heart, right? All right. I'll just keep talking to myself. So we want to limit fluid intake so that we can decrease the demands on the heart. And we're going to provide symptomatic relief. So they're just uncomfortable. They have this high fever. And if anyone's had a high fever, like 104 fever, it's the fever that makes you feel like crap. Like you feel like you've been hit by a ton of bricks if you have a high fever. So we really want to try to keep the fever at bay, although it's hard, and really just do a lot of mouth care and skin care. Because of the vasculitis, they're just super uncomfortable. And the biggest thing we're going to teach parents is that they have been on these high doses of IVIG. So they can't get their live vaccines. When is it most common to get this disease? Under 5, right? When do we get all our vaccines? Under 5. So this is when the kids are most at risk, and this is when they're getting all their vaccines. So it's super important to educate them because maybe they never saw their primary care doctor. It is very common for people to use the ER as their primary care doctor, all right? They come in all the time. I once had a person come in and tell me that this was totally off topic, but that it was 2 o'clock in the morning, and they came in, their chief complaint was the baby was crying. And I was like, it's 2 o'clock and like, that was it, the chief complaint. They had gone to an IMAX movie and brought the baby with them and hadn't fed the baby in 6 hours, the 2-month-old baby. I was like, give me that baby. And I fed the baby and wrapped the baby and put it to bed and went right to bed. Like, people come in for the ER for all crazy things. So it's not uncommon for them to come in and get treated for their Kawasaki in the ER and then go to their primary care doctor to get their immunizations, because you can't get immunizations in the ER. So oftentimes the primary care doctor doesn't know about the illnesses, and parents are not always forthright. And sometimes it's not even malicious. Like, they've asked me before, I'm a medical professional, and they'll be like, any changes in your son's status? And I'm like, no. And my husband will be like, he was in the ER like 2 weeks ago. And I'm like, oh yeah. I was like, yeah, that was nothing, you know? So even as a medical professional, people just forget. So, you have to ask those questions. I know it seems stupid and silly, but it's our job to ask those very obvious questions and say, like, please, has your child been sick recently? Have they been seen in the ER? And to tell the parents, if your pediatrician is going to give you immunizations, you have to tell them that you were treated for Kawasaki, because they cannot get which of their live vaccines? You just had it in test 2. Varicella, MMR. Good job. You have to remember those. Yeah, the OPV, but we don't use really that one. Yeah. All right. They can't get the live vaccines for 11 months. All right. So there are like 3 phases of it. So we diagnose it by the clinical manifestations. They have to have 5 or 6 of these. But they present in a very systematic way, okay? The first phase is that acute phase, and like I said, it's when they have that fever that's not responsive. So that's a lot of time. Fever freaks parents out. And I try to tell parents, like, fever is a good thing. It means that something bad is happening in the body, and your body is trying to fight it off. In fact, there are many studies right now that are saying not to treat a fever because it helps kind of kill off whatever disease. Yeah. Yeah. So there's lots of things that say. But basically, that's what freaks parents out, and that's what brings them in. They'll say they have a fever and I couldn't treat it. This is where they tend to be very irritable, but you have to keep them calm. All right? Remember, if they're pissed off, if they're upset, we are doing what to the heart?
More demand.
Increasing the demand, right? So if we're increasing the demand of the heart and they have a vasculitis, meaning that their vascular system is very inflamed and sensitive, they're going to be at really high risk for developing a coronary artery thrombosis, stenosis, or aneurysm. Okay? So basically, they're at risk for a heart attack. A little 4-year-old is at risk for a heart attack because of this vasculitis. If their heart, and that's again a big reason why they get the aspirin therapy, because we want to prevent this thrombosis. We don't want them to have coronary artery thrombosis, where they basically just clot off the coronary artery and have an MI, or that they get stenotic, or worse yet, they have an aneurysm and that coronary artery just burst and they bleed out and die. Now, are those super severe symptoms? Yes. Is it a little dramatic to talk about it? Yes. But are they at risk of it? Yeah. So we do. Most kids do just fine with Kawasaki. But we do need to educate parents because there are those kids that have these severe symptoms and we want to prevent them. Which one?
The A, the stenosis.
Aneurysm.
Do you know why there's an aneurysm? You don't know what an aneurysm is, right? We had an aneurysm, we had a patient die of an AAA and had an abdominal aneurysm.
No. And they're again, remember they're super hypervascular. So they are more at risk for clots. They have a really high SED rate. Remember, this is an inflammatory process, so their SED rate's really high. they've got that inflammation. They have a weakening in the vessel, like Mr. Schwab was saying. And so they're just really at risk for that, thick blood. Anything that puts pressure, if they're going to put at risk for that clot or that weakening to just kind of burst. So that's why we need to keep them calm. The last phase, basically, this is when they're all healed, but it can take 6 to 8 weeks for the labs to go back to normal. So that high SED rate, that whole systemic inflammatory process that we diagnose with the white count and the SED rate and the CRP, all those can continue to be elevated for up to 2 months after the disease process. So we need to just educate parents that even after all the signs and symptoms are resolved, we still need to take it a little easy with the kid because they are still going to have some abnormal labs. So they may look okay on the outside, but inside their body is still healing. All right. There's the strawberry tongue. And it's pitted just like it's pretty cool, I think.
Not for the kid.
Yeah, not for the kid.
Just the,
So, all right, and it says have a great week, but not yet because
we gotta do that.
we still have another lecture. Yay! All right. So, any questions about acquired congenital heart defects? So we know congenital and acquired.